Hi, today we're going to talk about chapter 13. In previous chapters, we talked about how the typical non-disordered brain behaves after drugs. And in this chapter, we're talking about how the non-typical disordered brain behaves after drugs and treatment. Mental disorder is defined as impairment in normal, behavioral, cognitive, emotional functioning. For someone to be diagnosed with a DSM mental disorder, there usually has to be significant emotional distress in functioning at work, home, school, or other important areas of life. And typically, before we make a mental disorder diagnosis, we want to make sure that the symptoms are not related to any medical condition such as Alzheimer's, cancer, or stroke. Any of these medical diseases can lead to psychological disorders. So once the medical doctor confirms a medical diagnosis, then we can determine how that diagnosis is impacting their functioning. For example, Jimmy goes to the doctor who diagnoses him with Alzheimer's with dementia because he's starting to show decline in memory, language, and task completing skills. A responsible doctor would refer Jimmy to a specialist or psychologist to help with his declining cognitive skills. The psychologist would review Jimmy's medical records, get detailed information about the family, do an assessment to determine what the deficits are that he has, and then determine a diagnosis. So then with all this information, they can determine a treatment for Jimmy. So the treatment would include informing the family of what to do if Jimmy forgets where he lives, his name, how to do daily tasks. Eventually, he may forget how to eat. After getting the results back from the assessment and reviewing all of Jimmy's history, the clinical psychologist would likely diagnose Jimmy with a neurocognitive disorder due to Alzheimer's. So that would be the diagnosis. So we don't diagnose him with Alzheimer's, that's the medical doctor's job. We diagnose him with a psychological disorder that's associated with Alzheimer's. So he has cognitive issues due to the Alzheimer's. We can't treat the Alzheimer's, we can treat the cognitive issues. Another example would be Jane, who has brain cancer. The cancer would be diagnosed by the medical doctor. If she starts forgetting what happened like 5 minutes ago, if she forgets her name, blanks out for minutes at a time, and sometimes forgets how to use the computer or phone, things like that. These symptoms are psychological. The medical doctor usually doesn't treat these symptoms, so as a psychologist, we would have to assess her. So after the assessment, we may determine that our symptoms are mild and that it's typical to experience these with her current condition, or we might find that these are significantly impacting her functioning and then write a referral for what she can do to help her with these changes. Let's say John also has brain cancer, but he doesn't have any cognitive changes. We don't diagnose him with anything. Medical doctor would be like, well, he has cancer. And then John would be like, well, I don't have any issues. They haven't determined any issues. So then he wouldn't get a diagnosis of a mental disorder. So not everybody's going to be the same. We only make diagnoses for someone who, again, is experiencing significant distress or significant problems with their daily functioning. We don't want to overdiagnose. If symptoms are so mild that it doesn't really affect them day to day, a good psychologist would just want to monitor the symptoms and make sure that they don't get worse. Another example of what medical versus mental. So if someone has a stroke, even though a psychologist may know how a stroke patient presents, we can't make a diagnosis for stroke, right? Because we're not medical doctors. A medical doctor would determine the stroke. Then if they show signs of anything that has to do with their cognition and emotions, that's where the psychologist steps in and assesses for a possible mental disorder. Depending on their symptoms, they may meet criteria for cognitive disorder diagnosis because of cognitive deficits and or emotional disorders such as depression, because they may become severely depressed for not being able to function like they did before. So again, anything that has to do with biological, typically something you can actually identify with scans such as PET, CT, MRIs, or through labs, they are all associated with medical disease or medical diagnoses. Anything that has to do with change in brain functioning or emotions are mental disorders or mental diagnoses. Make sure you know the difference between medical diagnosis and mental diagnosis and how they may be associated. Now that we know what's what, let's talk about how depression is diagnosed and defined. Anytime there are symptoms indicated by the letters in the DSM, such as the A through E you see here, the individual has to meet or show signs of all of the lettered criteria in order to be diagnosed. We don't want to overdiagnose. Think about it. If there were no specific limits or criteria set, then everyone and anyone can be diagnosed with this disorder. Major depressive disorder is characterized by 5 of the following symptoms over a 2-week period. That means this person has to show signs of these consistently during these 2 weeks. Either depressed mood, markedly diminished interest or pleasure in almost all activities, significant body weight change, and not due to dieting. So this person is just like losing weight and not intending to. Disruption in sleep, they can't sleep or sleep too much, fatigue or loss of energy, psychomotor agitation or slowed movement, just like really sluggish, feelings of worthlessness or inappropriate guilt, feeling bad about everything, even if things are not their fault. Diminished ability to think, concentrate, make decisions, recurrent thoughts of death, suicidal ideation with or without plan. Let's say Walter had to have signs of at least 5 of these symptoms within a 2-week period. B, symptoms caused clinically significant distress or impairment in school, occupation, or other important areas of functioning. Walter tells you that he's been late to work every day, not finishing his work because he has no energy or motivation, and has been reprimanded for it. He could potentially lose his job. He also can't concentrate, which is causing him to fall behind on schoolwork, and he might fail his classes. These are 2 really big issues that have great consequences, so they are significant. He would fit criteria B because it's causing him distress or impairment. And in this case, it's impairment. C, symptoms are not due to a substance or medical condition. It's mentioned several times earlier in chapters that drugs can cause depression because of biological changes in the brain. If someone is feeling really good because of drugs that increases serotonin and dopamine, after the drugs wear off, they likely feel depressed because the brain is depleted of those neurotransmitters, right? There's a rush of it, influx of it, and then when they come off of it, there's a depletion. So if the drugs are causing the depression and we take away the drugs, there's no more depression. So in that situation, we don't diagnose depression until we can for sure say that the depression is not associated with the drugs. Same thing with medical condition. If someone has a tumor in their pituitary gland and it affects their hormones and neurotransmitters, which can lead to depression, then it's the tumor causing the depression. Remember, the point of making a diagnosis is to formulate a treatment plan to help the person feel better. So if the person is experiencing depression because of the pituitary tumor, we can treat the depression until the end of time, and the depression is not going to go anywhere because the pituitary gland will continue to cause the person to have depression because there's an imbalance in hormones and neurotransmitters. You have to treat that first before you can actually treat these symptoms. With pituitary tumors, the person could potentially feel fatigue all day, every day. How are you going to incorporate this into the treatment plan? This is going to be a psychological treatment plan, right? How are we going to fix the diminished interest in activities? The person doesn't have any kind of energy, and they don't even want to be interested. If they were interested, they wouldn't have energy to do what they usually do to have fun. So this is when we are like, get the pituitary gland under control first, then we make a diagnosis. However, that's not to say we're not going to treat the person if they're feeling so bad that they can't function in their daily lives. We would just give them a provisional diagnosis. This means that before we can solidify a diagnosis, like say right now the person comes, we find out they have a pituitary tumor and they're also depressed. Well, which came first? Let's see if we can treat the pituitary tumor, get it under control, and during that time, we can still help the person try to feel better, teach them some coping skills, do some therapy, and we would give a provisional diagnosis, which just means that we're still monitoring it. We're still looking for more information before we can make a solid diagnosis. So it's temporary. But we have to have a diagnosis down because we need to come up with a treatment plan, and the treatment plans are different depending on diagnoses. D, not better explained by another mental disorder. Many disorders overlap, meaning that there are a lot of symptoms that are also criteria for other disorders. Again, one of the main reasons for making a diagnosis is to inform treatment plan. If we have too many diagnoses that are similar, it would be redundant and really impact how we help the person. There has never been a manic or hypomanic episode. If they have had either, it would be a bipolar diagnosis and not just depression. And treatment for bipolar is extremely different from just treatment for depression. Then we also have specifiers, such as what's the depression associated with. It's going to be different from person to person, and these specific specifiers help inform treatment, such as if they're going to need medical care, medication to treat their depression and anxiety. The depression could be associated with pregnancy or post-pregnancy, whether it's coping with being pregnant, worrying about not being able to care for their child, and or biological issues because there's significant changes in hormone levels that can change a person's mood. It also may be seasonal and only occurs during holidays or around their birthday, maybe around the time of someone's death that was important to them. They may experience psychotic features such as hallucinations or delusions, and they might also experience anxiety along with the depression. Persistent depressive disorder. Here, the individual has to meet criteria from A through H. Okay, the depressed mood has to occur for most days for at least 2 years. They would have had to have at least 2 of the symptoms listed here consistently with no break for at least 2 months at a time before we can actually diagnose. Criteria B: poor appetite, overeating, insomnia, hypersomnia, low energy, fatigue, low self-esteem, poor concentration, feelings of hopelessness. So it's similar to the major depressive disorder. C: in 2 years, they've never been without symptoms for more than 2 months at a time. And then D through H are the same as major depressive disorder. Same specifiers. So the difference between this and major depressive disorder is that this is going on for a really long time. Some people might have major depressive disorder, have it for 2 weeks, have it for 6 months, and then be done with it. As soon as it reaches 2 years, because they've had consistent symptoms, then it becomes dysthymia, persistent, right? It's persistent depressive disorder. It's not going away. There are physical or identifiable changes in the brain when someone experiences depression. The amygdala, which is the emotion center of the brain, can appear overactive in some people with depression. When Drevitz and colleagues analyzed depression in PET scans, they found that there was an increased blood flow in the left amygdala and increased glucose uptake. I'll let you go over the changes on your own because they are very straightforward. Antidepressants are used to treat depression and bipolar. They work by elevating neurotransmitters in the brain, such as dopamine, serotonin, and norepinephrine. By the way, where it says no longer used in the US, but still used in other countries, this was actually like this and had its own bullet point. So it looked like I was saying antidepressants are no longer used in the US, but in actuality, it belongs with this medication that is no longer used in the US. So antidepressants take at least a couple of weeks to start working, and there's quite a bit of the population that doesn't even respond to them. So it's important that there are other methods being used, such as psychotherapy, because long term, that's the most effective. Antidepressants also may have side effects, so sometimes they increase the symptoms, make the person feel worse, cause nausea, headaches, slow response time, diminished libido. So imagine if all that happened to you. Like if you're already depressed, I mean, we've all been depressed, maybe even slightly depressed at some point. Imagine feeling all those things on top of already being depressed. Like that must be awful. Medication oftentimes is like an umbrella, and depression would be like the rain. If it's pouring outside, the umbrella will keep you mostly dry, so the medication may make you feel better. But once you take that umbrella or the medication away, then you're going to be soaked. You're going to be back to being depressed. So rather than just relying on medication, the umbrella, we can take other measures to make sure that the person is protected from the rain, from depression, right? Because you can do other things other than use an umbrella. You can wear a rain suit, rain jacket, stay out of the rain, things like that. Transportation to get you from door to door. Some of you might wonder why I add things to the slides when I record the videos. Because we're not in a classroom, this is one method to help keep you engaged and your brain working. Just following along the slides with the lecture video can become mundane. So like you can hear the information that I'm saying, your brain matches it to the info that's on the slide. Then you think, oh, that makes sense. And you perceive that you actually understand the material because of the association it was made. It was made so quickly. Oh, I hear it, I see it, I understand it. However, your brain may not necessarily be proactively working. Rather, it's on autopilot. And autopilot isn't effective when you're retaining or trying to learn new information. So me adding things to the slides later on essentially is to help you keep you on your toes. Okay, so antidepressants are divided into 5 classes, which are based off of their pharmacological effects. Monoamine oxidase inhibitors, MAOIs, selective serotonin reuptake inhibitors, SSRIs, selective serotonin norepinephrine reuptake inhibitors, SNRIs, tricyclic antidepressants, TCA, and atypical antidepressants. Monoamine oxidase, MAO, are enzymes that break down neurotransmitters such as dopamine, serotonin, norepinephrine, and epinephrine. When too much of these neurotransmitters get broken down, depression and a whole lot of other mess starts to happen because then they get depleted, right? We need those. To give you an example, I use typing as a metaphor. Let's say each time you type on the keyboard, you're producing neurotransmitters, but your keyboard is glitching because the delete button is stuck, so it keeps deleting what you're typing. That's kind of like the enzymes. They metaphorically delete your neurotransmitters. You're typing, you're producing neurotransmitters, but then the enzymes keep coming and breaking them down. Monoamine oxidase inhibitors. So the last slide was about monoamine oxidase, which are enzymes. Now we have the monoamine oxidase inhibitors, MAOIs, which increase the level of serotonin by blocking the enzyme. So they stop these enzymes from breaking down neurotransmitters. So no more delete key option. You can just keep typing. The neurotransmitters can keep flowing and doing their job. And of course, when you need to, you'll hit the delete button. But ultimately, they will flow more regularly with the medication because it's blocking the enzymes from trying to bully you. It not only blocks the enzymes in the brain, it also blocks enzymes in the GI tract, and we actually need those enzymes in the GI tract to help us break down food throughout the body, brain and body. They're what help us break down neurotransmitters, foods, and others. It's like a garbage disposal. The purpose is mainly to get rid of unwanted elements in your body, right? To help us regulate them. When foods with tyramine are ingested while on MAOIs, such as like wine, aged cheeses, cured meats, they don't get broken down very well. So they stay in your system. What happens when you get an overflow of things in your system? It starts not acting right. Tyramine moves norepinephrine into the synapse. It causes buildup here, so tyramine will prevent the enzymes from working, right? The enzymes are what block the neurotransmitters, which are these little red dots, to get into the synapse, because the synapse is where the neurotransmitters go to work. Usually, the enzymes will block, or somebody with depression, the enzymes will block a lot of the neurotransmitters from going or staying in the synapse. When you take the medication, it kills the enzymes and it allows flow. But if you eat something that has tyramine in it, then this is going to block the neurotransmitters from going into here. So too much of something that happens, you see there's an overflow of norepinephrine, then bad things start to happen to the body. Too much in the synapse. Too much of everything is bad. SSRIs increase serotonin levels by blocking reuptake of serotonin transporters. The synapse is where neurotransmitters are truly effective. So if neurotransmitters keep getting taken back to the neurons, they're not actually doing any work. because we need them to stay here to work. Think of the neurons as your house. Okay, this is your house right here, and you're the neurotransmitter. And the synapse is the outside world. So this is your house, this is you, the red dots, and this is outside of the house, the world, the synapse. You could be proactive in life, working from home and ordering things to be delivered and never leave the house. But the quality of life overall would be very poor, right? We need the sun for health and happy, business to take care of, socialization to an extent. So we do have to leave the house at some point. So as a neurotransmitter, you need to get into the synapse, which is the world, to be fully effective in your well-being. Imagine if this is empty right here, right? And this is what makes our world go round. If this was empty, nothing is working. SNRIs enhance the levels of serotonin and norepinephrine by inhibiting the reuptake of their neurotransmitters. They can cause similar side effects as SSRIs, and they're used to treat depression, anxiety, and pain. Tricyclic antidepressants, TCAs, are drugs that inhibit reuptake of norepinephrine and serotonin, and they also block receptors as well, which is why they can cause so many side effects. TCA blocks those neurotransmitters. So this is TCA, the green. It blocks the neurotransmitters from going back into the neuron. It keeps them in the synapse so that they can continue to work. Atypical antidepressants are different from other antidepressant classes. They don't work like MAOIs or tricyclics. MAOIs and tricyclics increase the levels of norepinephrine and serotonin. Atypical depressants do that and more, but not all in the same medication. For example, bupropion is a norepinephrine and serotonin reuptake inhibitor. Reboxetine works as a selective norepinephrine reuptake inhibitor. Trazodone blocks serotonin reuptake and serves as an antagonist for multiple serotonin receptors and blocks histamine receptors, which is what causes the sedation. So far, you can see that atypical antidepressants work differently. They don't just increase neurotransmitters, they also have different functions. Then we have psychedelic antidepressants, which are drugs that are approved for depression treatment, and they have psychedelic effects. The effects may start to kick in almost immediately. So with other antidepressants, it might take weeks for it to start working, but with this, it can start as soon as the day after use. And typically, the psychedelic effects will end, and then the antidepressant effects will take over. So the person's not going to be experiencing the psychedelic effects the entire time. Psychedelic benefits also include that they don't have to be taken daily. They can be administered within days and or weeks apart. And lastly, they have a longer lasting effect than other classes of meds. Depression has been reported to reduce after weeks or months. The most effective way to treat depression is combining therapy with drugs. That's if drugs is even needed. Drugs act as a band-aid. If you have an injury, the band-aid can mostly protect the injury from further insult, but there will still be a scar because there's nothing to protect the injury long term. So sometimes a band-aid and something else is needed for long-term benefits. Psychotherapy acts as the scar remover. Thus, if both are used, your injury is protected from further insult and the scar goes away. There is a common belief that bipolar is defined by mood swings, like someone will be angry one moment and then be okay 5 minutes later, or be in a good mood 5 minutes later. Bipolar is actually characterized by mood changes between depressive and manic mood states. We already know what depression looks like, and the shortest time that we can even diagnose a depression is if the person has had depressive symptoms for 2 weeks or more. So it's not like mood swings, and people don't flip to different moods after being depressed. Mania is an abnormal elevation or irritation of mood, such as pressured speech, or just feeling like you have thoughts in your head that have to be spoken out loud and you can't stop because the thoughts are flowing really fast. So you have to get that all out. So it's really pressured. Going days without sleep but still feel refreshed. Impulsive decision making, like going out to buy a house without even planning or having money to buy one. I know somebody who actually disappeared for a week. She's in the entertainment industry and has businesses. So, no, when no one could find her, it was a huge shock. She decided to go on holiday without her phone, without packing a bag. She just got up and left. She left like she was high and didn't have a care in the world. And she actually doesn't use drugs. So we knew that we could rule that out. She had a manic episode. Mania also includes recklessness, behaviors such as having unprotected sex with random strangers, not just one. Some may experience delusions and hallucinations, and not just from going days without sleeping. Delusions and hallucinations can occur anytime during mania. Some may feel a sense of self-importance. They may feel like they can find a cure for COVID, or that they're really important, or that they're really famous. I'll let you go through the meds on your own. You really don't need to know much more about the meds for bipolar other than what is here. Don't break your brain. But you might want to go over this on your own. It's pretty straightforward. That's all for today. Talk to you next week.